Yeah. So these it's not a it's a mild, but it's not a it's not terribly infected. It's painful. These are painful. This is like a compressional neuropathy, man, because the nerve coming down, the nerve flows right through here. Okay, the nail is impinging it on this side, and then the swelling on that side. Guess what you have to do each day? What you put on? Shoe. So, boom, you get this thing, and these can be so painful. It's incredible. In the old days, we used to go and take the whole nail off, which is, guess what? More painful, right? So now you just take the corner away, and so today we can give them a nerve block here and there, and just slide this corner away from about here down to here. You got to go underneath the nail, this fold, because the nail actually grows from about there. So the mistake people do make when they go for ingrown toenails, they only take the piece they could see, but it's like a tree. As much as above the ground, there's as much underneath. So I want you to get a good picture of this. When we take that out, you see how much is underneath it. You're like, geesh. But that's what an ingrown toenail is. It's more of it in the flesh than is above the flesh. So we can take this corner away, and you'll see that all that nail comes all the way down in there. And the pain is that the nerve is in the middle. So when you decompress this area now, the pain stops immediately because it's something pressing on the nerve. Ingrown toenail, just like having a toothache or a root canal. It's pressure on a nerve. And boy, he ain't nothing to play with. Young, fit person, still, we're going to check his pulses. Still, we want to know he has good sensation. Still, we want to know that he is fine, okay? So that's what we're going to do. Pinprick there, on there. We get a good picture of it. It's not infected. It's still post-op. I still give them a little pain control, a little antibiotic, because feet always have germs on them. Don't believe you would get it very heavy do. Say, no, you don't need nothing. You give them something anyway. They always have germs on them. So we're going in here, take that corner away, and get the nerve freed that is in there. It's going to be quite good. All right? So, here we go. Close your eyes for me, sir. This is one. Close it. No, we're not going to do anything yet. You can sit up. Close. I just want you to see.
Close my eyes.
That's fine. I want to see. Do you feel this? Can you feel me touching you? Which foot am I touching you on?
The left.
What foot am I touching you on now?
The left.
Which toe am I touching?
The hallux.
Oh, you want to get fancy? Excuse me. Okay. What foot am I touching now?
The right.
Okay, fine. So still, you want to make sure we have bounding pulses. So put your hand on right there for me, Dr. Thompson. You feel that? Yeah? And then we also want to, and I like to do this with the patient in the room and with them awake. That's another thing about putting people to sleep. You know, they ain't got no recollection of what's going on. And they sign these forms for you to do all this stuff to them, and they didn't know what happened. I want you to know what happened, right? So I like for them to hear and feel what we're doing to them, so we know that the large blood vessel that comes right to the toe, Dr. Farquharson's lecture is so good, flow to the toe. And so important. That blood vessel going all the way to the toes needs to be competent. This is one of the gold standard tests of that competency. Even sometimes your hand could fool you. Why? You got a pulse in your hand too. Okay? And sometimes you may want to feel the pulse so bad you think you could feel it. Right? But in these cases, it's nice to just let's go ahead and see if we could hear it. confirmation for me, flow to the toe. And guess what? The patient, can you hear that, sir?
Yes, sir.
Okay, we're good to go. They do have machines too that give you a little printout. So you know, before and on a high risk patient, I think sometimes that's really nice too. So you have documented evidence that at 2 o'clock on Friday, we had XYZ flow and da 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 dum. Because sometimes, you know, last week I operated on the gentleman, he's 101 years old. Man, from day to day, you don't know what could be going on there. But you may need to document one day what was his capacity last week Thursday. The blood was flowing. But how you know? Only you and him in the room. You don't know. How do you prove it? You don't have any documented evidence of it. So sometimes they have a little printout. So you do that and they give you a little printout, stick that in the file. Just in case. And all the patients you meet are not, you know, going to be so nice. Sometimes people get very upset and they want to blame somebody and then things go wrong. That's also part of a doctor's job. You've got to take the blame. You know, the phrase Granville Bain used to use, say, boy, when you're in charge of something, you get the credit for the sunshine. And you get the blame for rain. And you ain't in charge of none. But your name on the list, right? You're getting the credit when the sun's shining, and when it rains, they blame you too. And that's a part of it. So you explain it to people. These things are called informed consent. That's why you go through the thing. I like to draw, because sometimes the words we use in medicine are maybe more technical than patients wish. So, you know, you want to draw it, show them, put the arrow, put it on, boom, explain that, and then you're good to go. And when they're happy, you should proceed. If a patient says, well, I'm not sure of this, then say, okay, we'll do it next week. Right? It's informed consent. The person must understand what we're doing, and then we do it to the best of our abilities. And you're good. And the results are great that way. All right, so he's going to get up, we're going to walk him through the next room, and we're going to start and get cleaned up. So the next thing I want to talk about today, Tomiko is one of our staff members, one of our star staff members, right? And, you know, we had this thing years ago, you don't operate on your family, you don't operate on your staff. When I came home, man, the first big procedure I got called in on was Dr. Earl Farrington Mitchell. He was the chief of surgery. And he had ingrown toenail, and someone had done it a couple times. And he's like, man, I want y'all cutting my foot, and we used to do a big Zadok, flap it up, put stitches in it, the stitch go through the nail. He said, no. Danny, come do this toe. And I was like, no, I don't want to do it. I don't want to do it. He said, you have to do it. I said, why? He said, because I'm telling you, I want you to do it. And I'm like, well, jeepers creepers, why I didn't want to do that? And I asked myself, yeah, I suppose operate on your colleagues and your family and stuff. He said, my friend,
My friend today.
may related, and I don't know you. Get this thing done. Because take a photo.
I know you.
And so, you know, I did him, and then after that, it was weird, you know, my daughter playing golf and Grace them fooling around the golf course, get hit in the head, put in the stitches, you know, something happened to one of my sisters, you do the thing. So let's put this foot down, put that foot over, put your left foot over, good, nice. So this one is the star of the day, all right? So this is a great procedure to watch for people because ingrown toenails, sorry, does that hurt? Oh, yeah. Sorry. So that even hurts to rub. Okay. Ingrown toenails are, of course, again, one of the most frequent things people will see. One of the most frequent procedures done, but poorly done. And so they got a bad reputation. So today we'll try and exemplify how it should be done and give it a good reputation. So, Mr. Marshall, you feel a little pinprick here and then there, and your whole toe goes numb, okay?
Yes, sir.
Tell us when you're ready.
Just a second, still feeling it,
Okay.
man. Ready?
Okay, you ready? Look, you're going to feel the cold spray right there. Mm-hmm. Good. Hold the stick right now. Pressure. Okay, you're doing great. Fantastic. Pressure again. You feel a little pressure down towards the base of your toe. Okay, doing great, man. Excellent. Fantastic. Well done. Same thing on the other side. So nerve blocks, we call it an H block if it's properly done, Thompson. You want to do the nerves now. One is dorsally and one is plantar on both sides now. Okay, so I go, you want to see a little wheel, all right, and right above it. Okay, and then I want to go right through, don't take it out. Down right to the bottom, you can see it raised to the bottom. See it raising? Okay, so there's a nerve here, a medial dorsal branch, medial plantar branch. All right, and I want to see it raise, and then I'm happy. I'm doing this side, and so I like to, this is the H block, we call it, very important. These communicate to each other from side to side. So you could fool yourself thinking I got it perfect. Still go across the top now. Okay, you go across the top. It's like an H. You know, you draw an H. So I'm going to do an H now to catch the communication that may come from one side to the other when we're in business. Shops. Okay. The biggest part now with ingrown toenails, I want people to know, is make sure you use an incredibly small needle. That's a 25 gauge, 1.5 inch. And stick people as little as you could. Don't you go with a big needle, and don't be sticking people 4 and 5 times. It's to go right through here, zoom right down through there on that side, right down through here on this side, and right across the top. How you feeling? You're shaking a little bit.
Can't stop that.
Oh. Okay. Does it hurt now?
No, it feels funny.
Your toe is going to feel heavy.
That's how I feel.
Right. Good
Like it's
stuff.
vibrating.
Yeah. Okay. So we leave that. A couple minutes. We'll come back in and we'll. Very important. We're going to squeeze your toe as hard as I can. And, you know, normally your toe hurts. So we're squeezing it very hard. And we're going to squeeze it really hard. Does it hurt?
Absolutely nothing.
No pain.
No.
Bingo. So that's the first part of the procedure that goes well, is that you squeeze it. So it's not a diabetic. He doesn't have neuropathy, anything like that. But you want to do that test, and you squeeze that toe, and people say, oh, it's great. What does that do? Patient confidence. He now feels, okay, I think these people know what they're doing. Very important. Because the other flip side is true, too. If you didn't do that anesthesia right, the whole procedure going forward is fraught with difficulty. You have to stick them again, they get nervous, they get jumpy, they're not sure how well it's going or not. And then, you know, you ain't sure either.
I wish they did that for me when I had an ingrown fingernail.
There
It
you
was
go.
swollen, sort of like that.
Mm-hmm.
She just sprayed something and said, all right, I'm going to, and just
Move
I
it.
jammed the scissors in there.
And you felt that.
I was like,
Yep. So the squeeze test is important, people. And then there's no reason to have blood flying everywhere with any of these procedures. All this is about minimally invasive work. Why? You need to be able to see. Okay? So with this procedure, you need to be able to see what you're doing. So if you don't control the bleeding, you can't really see what's going on. And the nail plate, so all the skin is keratin. What we forget about the human body and do it a bit of a disservice, the largest organ on the human body is what?
Skin.
The skin. It's the largest, it's an organ unto itself. It has everything, right? And it is based on keratin. The nails, your hair, and the skin, they're all the same substance of different densities. So when you're going to play with them, they're all the same thing. You can't just cut them and push them aside, right? They will not respond nicely. You have to kind of, and I'll show you now, you really have to separate them gently. Okay? So in the old days, we used to do this procedure. You used to cut right down through there, right? Cut right down, blood come out, you go in there, scrape down the bone, and you don't have to do any of that. I'm wanting now to separate the nail, okay? Separate the nail from the skin. Blunt dissection. They will separate. This goes all the way to there. the old Zadoks, and Mitchell and I, when we were trained, I used to wonder why they thought that was torture. Right? Wonder why they would do that. So I separated the top, now I want to separate the bottom. Sometimes the top has a little infection in that part, so I change over. I want to go under here with a sterile instrument to the bottom. See how far that goes in? In the old procedure, sometimes you do it with a sharp dissection. I'm on the bone. If you have a sharp dissection and this is infected, you could get a periostitis that the doctor calls because you've gone with the blade and now we've hit bone. Okay? So now I know I'm in there. I got the other piece separated, blunt dissection. That's how far that goes. Okay? Nice and smooth. And now I know it's quite easy for me now to separate. This was when you had your procedure done, sir. We're now going to separate the different layers sharply. Boom. And this is interesting now because you saw, telling you, it looks like there's only a little bit of stuff in there. And now you're really going to see what all is in the skin. Alright, so this is the ingrown toenail. Watch it coming out. Coming out. Boom. That's what's in his skin. That's the pain. Okay? That's the pain. Okay, we get that out. Nice and clean. Look at that. When you check this with the space available, how in the world, so that's the space that it comes out of, how does that fit? And it's constantly proceeding, so it's cutting through the flesh. That's what an ingrown toenail. This is that's a little piece of space available. So come around the back of me, Dr. Thompson, you could look. This is why you need to be able to see the thing. That's the little hole it comes out of. You know, Sesame Street had one of the great ads. One of these things does not belong here. And cosmetically, I like when my patients do look at their feet again. It looks beautiful. So these things got to be nicely done and look good too. Phenol, please. So for me, I like to phenolize these. Phenol is a chemical agent. And in young people, I cauterize it also. Okay, so now that's nice and clean. See how clean that is? It's been bothering me for quite a little while. So I can get this now done. And let's do that side. Put a little phenol in there. Jinga, 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 ding, ding. Now you really see how deep that thing goes. I rotate it towards the nail, okay? Because I don't want any of it going underneath it. So me forcing any underneath it. So I'm going away from it and then out like that. Make sure I swab both sides. Phenol is turned off, the alcohol swab. By alcohol. I don't leave it in for long, literally seconds. It's chemical cautery, okay. I'll dab in the corner, I'm good. And my Bowie pen. Now I use heat cautery also. The heat cautery for me is where I don't have to worry about bleeding afterwards and all kind of stuff that people do, because I'm not going to use a suture. So you'll see a little puff of smoke come up here and there. The tip of this gets to about 190 degrees. Okay, so a little smoke coming out. Boom, a little puff of smoke. And look down in there again. Dry and clean. Okay? So when this heals, all wounds contract. So when this heals, it's going to come in to there, and that's your final result. That's how we should be looking, okay? So, good. Just got the alcohol. Let me go a little back to ground. Any problems, sir? Do you feel anything?
No, not
Good. I tend to let people if they want to, they can see their nail. They can have it if they want it. But this, that's his issue, and it just doesn't fit. Okay. Good. Thank you. And once again, it says blunt dissection, removal of all that nail, no pain, no blood. So I thank Earl Farrington for forcing me into this dilemma, because he's like, Danny, I don't want to see no blood, and I don't feel no pain. And he was the chief of surgery. And I'm like, okay. And we got it done. I think that's good. That's good. Got it done, man. So that's the classic ingrown toenail. It is a beautiful thing to do for people, but it has to be right start to finish. All right, you really got to be right start to finish. Very well done. No pain, no problem, no blood. Right. So another thing, although you know you got young men, they brave, people they won't see no blood. I don't care what they say, they won't see no blood. Good. There's a little bit of cling here. Any questions for us, Mr. Marshall? You can have your nail if you wish. It's yours. It's not ours. Comments, Dr. Mitchell? Raise the leg up a little bit. I put my bandage around ankle. People wonder why I do all of that. But like when people sleep in the night, these things fly off. Scissors.
What's the post-op course?
Post-op. We'll get his post-op thing. We'll see him Monday for a dressing change. At which point you get a nice, simple, dry dressing. We'll look at it again one more time, maybe later that week or the week after. And then he's on his way. He just, you know, he ain't got to see us no more. Good. Cut that for me. Zoop. Oop. Kaboom. So I can put one little loop around here. So, Thompson, you'll gather by now, I like very clean dressing. I like things that look good. Why? The patient's going to go home, their family's going to look at it. The dressing botchy and twisted up and, you know, little manky and look like he's fallen off. They think the surgery wasn't done right. And they might be right. But you want it to look good.
Sight is, you know, just like if you
Yeah.
see
Seeing
food that
is
looks nice,
believing.
you will more intent
Right.
to buy it than it looks.
I want us to look good. And people want, part of health is looking good and feeling good. And our thing is really wanting people to return to good health. And we do want when people see our work to say, oh, that's very nice. And they ask the question, and the question they ask him, did it hurt? That's the thing I ask him. Did it hurt? And we don't want to be like my friend in the corner. They would say, "Boy, that again."
And it's good PR because once people see the dressing nice, then they tend to, oh, we can tell this person, and then they're more likely to, you know, the bush rate is better and all these other things that go around. So,
Okay, we have a minor, small tourniquet on this thing, so you always remember, you know, take that off and slide it right from underneath, slides right out through between the sulky. Ding 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 ding. I like to put this under there, a little cushion. Boom. The ingrown toenail, man. Thank you very much. That's it. And you'll get your post-op instructions. You want to do the elevation. You can move around. You can do stuff. Thank you for letting us do your work and trusting us with your life and limb. So people think ingrown toenails is so simple. We have in the Bahamas people who have died having an ingrown toenail done. One of our famous permanent secretaries actually died, and unfortunately he found out two things. He had a reaction to the anesthesia, So giving people anesthesia has, you have to be very careful. People can have can get an anaphylactic shock reaction to just simple anesthesia. It doesn't matter. And then we found out later he was a sickler. He had sickle cell anemia. So people who have sickle cell anemia, when you're dealing with digits, your hands and feet and stuff like that, you have to exercise extreme caution because any change in the hemodynamics of their extremities could trigger this reaction. And in his case, it wasn't just, you know, if people think of sickle cell anemia with a painful crisis, they can also throw off thrombi. So he had a thrombotic shower and multiple complications. Okay? So although you're going at these things, it looks simple. I want people to remember, you know, double check with the patient, make sure you know what's going on, take all the precautions. We have a crash cart there. We got a different equipment. We got a recovery room here. We have everything you need. And so take all the necessary precautions. It's safety first. This is a health and safety act that we're wanting people to join in with us for. And you want to get simple, safe results. But there are complications to go with ingrown toenails. One is reaction to anesthesia. Two, they can have post-op infections. They can come out of here and have a rainstorm and you step in a puddle and you know you leave the thing on a couple of days, you get a terrible infection. In diabetics, that procedure we did just now is the best procedure for that. Why? Because you're not injuring any other tissue. You're sliding that offending nail object out without injuring any of the tissues. And not using a suture, because a suture now is a foreign body that you're leaving in there for several days. They can have a reaction to that. Also, when you stitch on the tip of the toe, you can't see it, you could pick up the blood vessel or the nerve and have that in your suture line. Okay? And in a diabetic, they can't feel it, but you see the tip of the toe go black on you, and you're like, well, what happened? They lost blood supply. No, your suture might have compressed the blood vessel. Okay? So as you can tell, no suture. Why take that unnecessary chance and get that complication which could be dire? So that classic procedure, I was forced into doing it like that by Earl Farrington, the chief of surgery, because he wanted it done on him, and we did it successfully. And I figured, like, do it on him, well, you might as well practice this, do it for everybody. And that's what we're trying to push now, is that if you're doing the best thing, if I would do the best thing for Dr. Mitchell, because she's my colleague and friend, that's not good medicine. You should give Ms. Smith the same care you can give Dr. Mitchell. That's my nephew. I had to do it. He break his ankle and I have to treat his ankle. I have to do the same care as someone, do it on the road, begging in front of doing this. Give him the same care. Okay? And it should be the best we could possibly give people. And that's when you get joy out of this practice.
So Dr. Johnson, based on how they used to take the entire nail off, I'm sure the recovery time is longer than.
Take the whole nail off and you do a sharp dissection, 6 to 8 weeks recovery. 6 to 8 weeks. This thing, 1 week. 1 week and he finished. 1 week recovery. Boy, that's a big difference. If you're working, if you're working.
When we took the nail bed off, we used to just leave them. When we took the nail off, we left the nail bed exposed. So you had all that. Even though you were
It's a huge infective area.
Right, you still got
It's a
that.
huge area, and this could get infected. And that's a diabetic, 80 years old, 70 years old, poor blood supply. Why you want to do that?
And we kept interrupting the healing because every time they came for dressing change, and you took off that back right, you were disrupting the healing.
And as they say in showbiz, that's a wrap.